Hi, welcome to the Musella Foundation's webinar series. Tonight's topic is the DCVAX vaccine. And our very special guest speaker is Dr. Linda Liau, who is the chairman of the Department of Neurosurgery at UCLA and professor and director of the UCLA Brain Tumor Program, and is a former editor-in-chief of the Journal of Neuro-Oncology. Take it away, Dr. Liau.
Well, thank you, Al. Thanks for having me. I'm going to do a screen share and start with my presentation, and I'll take some questions at the end. So can you all see my screen okay?
Yes, perfect.
Okay, so today I'm going to talk about the paper we recently published on the phase 3 trial results. And kind of go into a little bit more detail about the details of that paper. Here are my disclosures. So, dendritic cell vaccines are actually, let me get rid of this screen up here. So, dendritic cell vaccines are really based on the concept of the dendritic cell. The dendritic cell is a professional antigen presenting cell. They're normal cells in the body, and they were discovered in the 1970s by Dr. Steinman. But it wasn't until the late 90s when people actually learned how to, grow these cells in large numbers outside of the body. And we were one of the groups that started exploring the use of dendritic cells as a vehicle for vaccines. So the concept is really taking the antigen presenting cell and then loading them with tumor antigens. And in this particular case, the antigens come from autologous patient tumors. The cell is then injected into patients, and that they thereby activate T cells. And these resting anti-cancer T cells can then grow and proliferate. They get activated, and then they can divide and proliferate, and then go on to the tumor site to attack the tumor. So we and others have over the years done lots of preclinical studies, and we were the first to do the early phase clinical trials on using this vaccine. And one thing that we do know is that dendritic cell vaccination does get T cells into the tumors, and the infiltration activation of T cells into these tumors are a necessary, although not always sufficient, first step in terms of activating an immune response to glioblastoma. We've done several early studies, with this vaccine in patients, many of whom are actually, still alive today. And one thing that is consistent among kind of the long-term survivors is that they do have, T cell infiltration into their tumors. So this is the schematic for the phase 3 trial. It was a phase 3 multi-center randomized clinical trial of autologous DC vaccination in 331 patients. The patients underwent screening and then surgery. Following surgery, they had a leukapheresis in order to collect the blood cells to make dendritic cells. Then, the dendritic cell vaccine is essentially a combination of the dendritic cell and the patient's tumor tissue taken at the time of surgery. And then patients underwent standard chemoradiation following surgery, during which time the dendritic cell vaccine was made. And then patients after chemoradiation were randomized to placebo versus DCVAX, and they were treated on days 0, 10, and 20 with the vaccine, and then had booster injections every 2 months for the first year, and then every 6 months for the 2 subsequent years. This trial was conducted at 94 sites in 4 different countries, including the US, Canada, the UK, and Germany. And just completing this trial itself was quite a feat. As you can imagine, there was a lot of logistical coordination that went into trying to get this trial started, and also the treatments to these various sites. But one thing it did show is that it is feasible and able to be done in a wide variety of of clinical settings, which I think is a strong point, because some clinical trials can only be done at very specialized tertiary and quaternary academic centers, whereas this is something that could be more widely accessible. So this was the patient enrollment. There were 331 patients. This was initially designed as a randomized controlled trial, so with 2-to-1 randomization, 233 in this arm, 99 in this arm, who got placebo. Of note, even though the trial was initially started in 2007, the recruiting was paused for economic reasons. Following the recession in 2008. So the majority of patients were actually enrolled between 2012 and 2015. So that's something to keep in mind when we talk about the comparative trials to which this trial was compared to. And the reason we compared this to external controls was because of this crossover arm. Because of the crossover arm, most of the placebo patients actually eventually crossed over to get DCVAX. And the few that did not cross over, many of those actually had either died or lost to follow-up. So there were very few control patients left for analysis, so that there was basically the control arm was depleted, and that's why we could not do comparison to that cohort. And one issue, and we've been very transparent about this, is the issue of progression-free survival. So when this trial was initially started, when the protocol was written in 2007, the endpoint of progression was supposedly was supposed to be determined using the McDonald criteria. But then, as many people may know, as the trial was underway, that the field actually began to realize the problems with using strict McDonald criteria for determining progression. So it went on to RANO, and then RANO was also not sufficient. So subsequently that's been changed to iRANO, and then there have been problems using iRANO as well. So that's why now there's been talk about using modified RANO, and the problem is essentially illustrated here. This is for instance, a patient who received vaccination, got received surgery, got vaccination, and then was noted to have progression based on strict McDonald criteria. But this patient actually clinically was doing very well, didn't have any symptoms, didn't have any other issues. And then over time, this area kind of regressed on its own without any further treatment. So in this particular case, this would have been deemed as a pseudo progressor, but at this time, we wouldn't have been able to know that. And during this trial, the radiology review was done centrally by two radiologists that were unaware of the treatment cohorts that the patients were on, and in over 50% of the cases, the radiologists themselves did not agree. So that, of course, made determination of progression-free survival very difficult endpoint. So when you have an endpoint that could not be reliably determined, that made that endpoint essentially very difficult to assess as a valid endpoint. And even with iRANO, when iRANO came on board, and iRANO stands for immunotherapy response assessment in neuro-oncology. I guess one thing that iRANO required was a follow-up scan in 3 months. But the reason move from iRANO to modified RANO is that you can imagine if you were a patient and you saw progression and the kind of response was, well, let's just wait 3 more months and get another scan. A lot of patients on clinical trials that used iRANO actually had to be censored because there was a lot of dropout from those trials. So I think the field is still trying to figure out how to determine progression in an immunotherapy setting in glioblastoma. But with all that being said, while the trial was underway, but before data lock and before unblinding, the statistical analysis plan that was submitted to the regulators was designed to focus on overall survival as opposed to progression-free survival. So this is the design of the statistical analysis plan, and essentially, because of the depletion of the control arm, because of the crossover, the primary endpoint was then written to include survival compared to external controls. And then, as you can imagine, when this was a trial done in the newly diagnosed setting, so when patients actually crossed over, they were essentially patients deemed to have first recurrence. So that group that crossed over were then compared to overall survival in clinical trials of recurrent glioblastoma. So this was the primary endpoint, and this was the secondary endpoint. So talking a little bit more about the statistical analysis plan, the first thing that needed to be done was to actually match the trials, to find the comparator trials to which to compare these patients to. This was the selection of the comparators was done by an independent statistics firm based on 4 predetermined criteria used to match these trials, which included kind of the contemporaneous time period from which the patients were enrolled into the trials, the similarity with eligibility criteria, and in treatment protocols. So of these, using these 14 criteria, there were 5 clinical trials that were done around that same time period that were used as comparators. So this is a graph showing the control arm of those 5 trials. And as you can see, they overlap quite a bit. Actually, they were quite consistent in terms of the kind of the Kaplan-Meier survival curves for the control arms of these trials. And this comprised over 1,300 patients that essentially received radiation and temozolomide. And this served as the control population. So in addition to taking these, these patients in the control arm of these trials, when I guess bias potentially could be introduced if there are different characteristics of these control arms. So we used an analysis called a MAKE analysis, matching adjusted indirect comparison. And this is used, it's actually used quite frequently in healthcare economics and in population health analyses. And what it does is it actually tries to compare individual level patient characteristics with the weighted characteristics of a population of patients, in this case, the control arms of these trials. And this is just a way to do, as close a matching as we can of these patients when individual level patient data is not available for propensity score matching. One thing that I would advocate for and hope for in the future is that when we do these large, trials, that the patient level data can be made openly available for comparisons for subsequent trials to be compared to. That I think that would be very beneficial to the field. But essentially, these characteristics were matched for each individual patient in our trial. They were matched to characteristics of the patients in the comparator trials, and they were matched for things like, age, extent of resection, MGMT methylation, and several other factors. So in addition to the matching, we then also did sensitivity analyses to check for comparator differences. So, there were 5 different sensitivity analyses that were performed, doing each of these comparisons, leaving out one comparator at a time. And even, with each of those analyses, the statistical significance and difference between the, our treatment arm and the control external control population did hold out to be true. We also did a 6th sensitivity analysis whereby we took out 2 comparators where it was unclear whether early progressors were excluded from their trials, and only did the comparison to the 3 other trials where they did, as in our trial, take out early progressors. And those data also showed a statistically significant difference. So basically with the sensitivity analyses, all the outcomes came out to be the same. And then, there was also specificity analyses that were done for validation of the external controls, because you could imagine one potential bias could be that if using this approach, you could erroneously have a negative trial turn out to be positive. So in a way to kind of control for that, each of the 15 studies that were used as comparators, the 10 newly diagnosed studies and the 10 recurrent GBM studies were taken, and we took the treatment arms of these trials and compared them to this external controlled population using the same methodology that we used for this trial. And what that showed was all the trials that were negative in the randomized control setting, when these randomized control trials are done, all the trials that were negative were still negative when they were compared to this external population of patients. And all the trials that were positive, which was only one, the TTF trial, actually did turn out to be positive. So at least, with this level of analysis, there was some validation that the negative trials, if a randomized control trial were done, were still negative, and the positive trials were still positive. This is the baseline demographic and clinical characteristics of the comparator trials. As compared to our treatment group, and then this is the pooled external control group, 1,366 patients. And quite frankly, I don't think we should be subjecting another thousands of patients to control arms of randomized controlled trials when the data from these arms are very consistent. You can see the Kaplan-Meier curve is very consistent, even among these different trials. So sorry, let me get back to my slide. And then, MGMT methylation was pretty similar, as well as kind of residual disease for the trials that we had that data for. These were the baseline demographics for the recurrent glioblastoma patients. Again, so in this population, there were 10 different trials amounting to 640 patients, and then the 64 patients that had crossed over constituted our treatment arm for the recurrent glioblastoma group. Here are some additional baseline characteristics of these trials and of our external control patients, as well as our treatment patients in the newly diagnosed DCVAX group, as well as the recurrent DCVAX group. I won't go through all the details other than to say that the comparisons were pretty similar. Of note, we also looked at IDH mutation because there's a thought that perhaps if there were a lot of IDH mutated patients, those could be why there was increased survival. And the percentage of IDH mutated patients was only 3%. in our treated patients, which was similar to the external controls. So this is the data. There was a statistically significant difference in median overall survival of our DCVAX treated patients compared to external controls. Granted, this was not a randomized controlled trial, and I realized the limitations because of that. But this is, given the circumstances, probably as close a match as we could perform to a well validated external control population. And then one thing I thought was particularly interesting was actually the different subgroup analyses, and which even showed even more robust hazard ratios when we looked at patients, for instance, who were, over 65 or who had significant residual disease or MGMT methylation. This is the Kaplan-Meier curve for the crossover arm. So placebo crossed over meant the placebo patients who crossed over to get DCVAX at recurrence. That group compared to the external controls from the external group. Oh, one thing I would like to note is that these tails are actually Kaplan-Meier estimates. A lot of these external comparator trials did not actually follow patients all the way out to 5 years. They ended, in less time than that. So these are not necessarily actual data on the external controls, but the Kaplan-Meier estimates based on the statistics. But with that being said, the difference is still, significant. And this is essentially the landmark survival rates based on the Kaplan-Meier estimates for the external control population. Our DCVAX group had a 13% 5-year survival in the newly diagnosed setting, and in 11% at 30-month survival. This may actually be higher in the if as more patients are living out past 5 years, but we stopped the analysis at at a specific time point, and so this is actually the Kaplan-Meier estimates at 13%. As far as the subgroup analyses, and I think there's some very interesting hypotheses that came out of the subgroup analyses that were somewhat unexpected, and I think would could lead to further studies in these areas. One is that there seemed to be a significant survival advantage in the patients over 65 who had the dendritic cell vaccine versus the controls. And that I think bode well for this having perhaps some effect in these older age group patients. Of note, this didn't mean that the vaccine worked better in patients over 65. It just suggests that it worked relatively better than the control patients who were over 65. Because if you look at the median survival here, it's 15.6%, whereas here in the patients under 65 was actually 19.6%. So it still works better in younger patients, but relatively better in older patients compared to the external controls. Then this one was actually very surprising to us, this subgroup analysis, showing that there's actually a greater survival advantage in patients with significant residual disease compared to minimal residual disease. And as a surgeon, we were always taught, and we thought that taking out as much of the tumor as is possible leads to a better prognosis. And that still is the case, because if you look at minimal residual disease, their survival is still longer than the survival in the significant residual disease cohort. But the relative survival advantage is greater in this group. And what that's kind of suggests is that, perhaps like I said, one thing that the dendritic vaccination does that we know it does is it gets tumors into the, or gets T cells into the tumors. And perhaps in order to have a more diverse repertoire of antigen presentation and epitope spreading, there may need to be some residual tumor still there, so that the T cells, once they get into the tumor and get activated, there may need to be residual tumor there to enhance the immune response and promote epitope spreading. Again, that's a hypothesis that probably needs further validation, but I found that to be very interesting in this particular case. And then another, subgroup analysis that turned out to show a significant survival advantage were the MGMT methylated patients. So you can see there's in this subgroup, the median survival was 30 months. But what I thought was particularly interesting was that when these patients got to about 3 years, the majority of these patients actually, continued to live on, but not just continued to survive. They actually did not have progression. So it could be that, in this particular subgroup of patients, there is a percentage of these patients, roughly about 20%, that do have a significant long-term survival advantage with the DC vaccination. And why it's more effective in MGMT methylated patients, we don't know. MGMT methylation may be a surrogate marker for something that we have yet to discover. Or there have been some reports that suggest that MGMT methylated tumors actually are more hypermutated, so they may have more mutations by which to induce an immune response. These are the relative percentages of long-term survivors and the overall DC vaccinated patients. And at the end of the day, it turned out that there was not a clear-cut prognostic advantage to some of these kind of known prognostic indicators, particularly as related to age or IDH mutation. Although MGMT methylation, you can see there's a greater extent of long-term survivors in the MGMT methylated group. So in conclusion, personalized autologous tumor lysate pulse cellular vaccines, such as DCVAX, appears to be safe with minimal toxicity, and it was feasible to administer this at more than 90 sites internationally. In newly diagnosed glioblastomas, there was a statistically significant difference in median survival in both the newly diagnosed and the recurrent glioblastoma patients. Again, this was compared to external control populations. This was not a randomized control trial, although the external control populations were matched as well as we could in this situation. It's probably the best we could have done given the data that we had. And then long-term survival, I think this was actually even more interesting that it was, significantly increased in our glioblastoma patients who received DCVAX. And it wasn't just 13% long-term survival. It was actually longer-term survival without progression, which actually was quite interesting. And again, there seems to be a significant long-term survival tail, more than 5 years without recurrence in the MGMT methylated patients. So I think that data is what it is. It is level 2 data. It is compared to an external control cohort. And I think, in terms of, where it'll go next, I think that's, still yet to be determined. But I do think that it is certainly a first, a step to really hopefully getting to more significant longer term survival in glioblastoma patients. And this was actually a review written by these authors, a year or so ago, that and it shows kind of the potential role of dendritic cell vaccination in combination with various different modalities. And I think this is really where it may have the most power in terms of future placing in the treatment of glioblastoma patients. Because one thing that, as I mentioned, one thing that we know dendritic cell vaccination does is that it gets T cells in to the tumor. And although that's sometimes not sufficient, it is necessary. So that's a very necessary first step to get the T cells in. Once the T cells are in, there is, and I won't go into that data today, but there is this kind of, microenvironment within glioblastomas that could actually deter an effective immune response. And some of that has to do with, checkpoint inhibition. Some has to do with this, population of immunosuppressive myeloid cells that come in. And, so there are different ways that we can modulate that with other agents. And that's something that we're looking at UCLA, is, we're looking at dendritic cell vaccination in combination with co-stimulatory molecules and checkpoint inhibitors. We're also looking at, some collaborations to look at CAR T cells in conjunction with DC vaccination and other types of protocols. And this is just some very preliminary unpublished data on our trial at UCLA, whereby we're combining dendritic cell vaccination with PD-1 inhibition. And what we're showing is that, interestingly, when we give PD-1 inhibition neoadjuvantly, before vaccination, you actually get a survival curve that's, this is actually better than giving just PD-1 alone. But if you give the PD-1 inhibitor after dendritic cell vaccination, you could even boost that survival rate up to greater than 50%. Again, this data is very preliminary. We're only halfway through this trial, so we don't have the final data yet. But I think it's encouraging in the fact that we probably can combine, vaccine therapies with other immune modulators to hopefully get a positive response for glioblastoma patients. So with that, I just wanted to thank all the investigators that were involved in the phase 3 clinical trial, all the co-authors on this JAMA Oncology paper that was, was published a couple weeks ago. And it was really, a wonderful group of people that I've worked with. And with that, I will stop and take any questions.